So Mr. G, a 29 years old gentleman, software engineer working in Bangalore, presented with complaints of fever for the past 8 days, vomiting for 2 days, loose stools for past 2 days. So history of presenting illness, patient was apparently normal before 8 days, then he developed fever associated with chills and rigor released after taking tablets. He also developed vomiting for the past 2 days. 3 episodes contains undigested food particles, not blood stain, associated with epigastric pain. More after eating food. He also had loose stools for 2 days, 5 to 6 episodes per day, watery, not blood stain, or non-mucor. He also had a headache occasionally, frontal relieved after taking tablets. No history of cough or breathlessness, no history of chest pain, palpitations, no history of any bleeding manifestations. Past history is doesn't known comas. Is not an alcoholic consumer or a smoker. So an examination is BP was 100 by 60 millimeter mercury, heart rate 90 per minute, saturation 100%, temperature is febrile 102.6 degree Fahrenheit. He has had a blanching macular rash present in front, no eschar. No pallor icterus, clubbing cyanosis, lymphadenopathy, or pedal edema. On systemic examination wise, it was unremarkable. So he presented the male patient presented with a syndrome complex of acute undifferentiated febrile illness. So the initial differences are considered were enteric fever, scrub typhus, leptospira, malaria, dengue fever, acute viral hepatitis, infective endocarditis, autoimmune causes like SLE, rheumatoid arthritis, and malignancy in the last phase. So investigations. These are these investigations during the course of stay in the ward. The hemoglobin is 12.4. Total counts initially was low. In the course of time, it became 11,000 and 8,000. Platelets, it because fluctuating like 87,000. Then in the end, course in the stay, in the end during discharge, it was like 2,92,000. His urea and create, urea is 21, create is 1.24. LFT, so it has some transaminators. So STOT of 181. And STPT of 128, alkaline phosphatase of 135, electrolyte sodium 130, potassium 3.6, and bicarb 15. So dengue serologic MS negative, scab was negative, malarial parasite 2 times was negative, viral negative, wheel felix negative, leptospirosis was negative, brucella was negative, blood cultures we sent 3 days, so it was negative. Acute viral hepatitis screen also we sent because of the transaminase, it was negative. But he was continuously, we started him on azithromycin and meropenem, but he was continuously spiking fever spikes in the ward. So we thought it was a pyrexia of unknown origin, and we started working for the cause. So he had spikes of 103 Fahrenheit, daily spikes without touching the baseline. So we did the echo. Echo showed no vegetations. So ejection fraction was 62%. Autoimmune cause ANA was negative, and cause was negative. So CT, we did a CT neck thorax abdomen. It shows the mesenteric lymph node, largest measuring up to 2 centimeters. So we plan to biopsy the lymph node also. In the meantime, we did a bone marrow biopsy. It shows cellular marrow with Eileen's hematopoiesis, lymphohistiocytic aggregates, and focus suggestive of hemophagocytosis. So we thought is of HLH. So fibrinogen is 339, it's low. Ferritin is elevated. Triglycerides up to 57. So we made a preliminary diagnosis of HLH, but the cause we don't know whether secondary to some infection or a primary HLH. So what's lymphohistiocytosis syndrome? So introduction. Hemophagocytic lymphohistiocytes is a life-threatening hyperinflammatory syndrome characterized by unchecked immune response, macrophage activation, and cytokine surge. It can be primary as well as secondary. So incidence of secondary HLH is unknown. So what is HLH? Is usually defined. It will fulfill the HLH 2004 criteria. I will be telling the criteria later. So hemophagocytic syndrome, it should also satisfy the HS score. This will be explained in the later. So what is a MAS, macrophage activation syndrome? It's a hyperinflammation syndrome caused by autoimmune or autoinflammatory disease. This is more or like an HLH. HLH is mostly due to some genetic cause or due to malignancy or due to infection. If it's macrophage activation syndrome, it is mostly due to autoimmune or autoinflammatory cause. So pathogenesis. So any genetic infection, malignancy, or autoimmune disease is activates cytotoxic T lymphocytes. So it activates the macrophages due to cytokine storm. So mature cells as CRT express, calrectilin expression. It's a eat me signal. So mature cells has more of this CRT expression. So macrophages will phagocytosome easily. So it HLH is also cause reduced expression of CD47 expression in the hematopoietic stem cells. So it is an anti-phagocytic in action, but CD47 is reduced. So macrophage will easily phagocytose them. So it causes hemophagocytosis. So the criteria. So new criteria is 2009 HLS criteria. The patient should have at least 3 of the following: fever, splenomegaly, or cytopenia, hepatitis. Then a patient should have at least 1 of ferritin elevation, CD25 elevation, hemophagocytosis seen in bone marrow, lower absent NK cell activity. The other supportive evidences is hypertriglyceridemia, hypophosphatemia, and hyponatremia. This is a height score. So we should we should score the patients. So the score contains some underlying immunosuppression, temperature, organomegaly, number of cytopenias, ferritin, triglycerides, fibrinogen, AST, and hemophagocytosis. So it is very difficult to differentiate between sepsis and HLH in these settings, because fever will be present in the both sepsis and HLH. Organomegaly will be present. Cytopenia may be present in both sepsis and HLH. Triglyceride, fibrinogen, hemophagocytosis may be present in sepsis. Soluble I-25 is absent in sepsis, is specific for HLH. NK cell activity is present in HLH and absent in sepsis. So the soluble IL-25 and NK cell activity can be used to differentiate between sepsis and HLH in this setting. So infections can trigger primary HLH, or it can be cause of secondary HLH. So what are the infections causing this HLH includes EBV infection, cytomegalovirus infections, herpes simplex virus, HIV, histoplasmosis, leishmaniasis, and malaria. Bacterial infections like mycobacterium, tuberculosis, brucellosis, gram-negative bacteremia, entry fever also causes secondary HLH. So it's a case, it's a systemic analysis taken from there. So 43 case reports and case series are included in the analysis. So here in this series, the emergence of HLH feature started in the second week of illness. So in all patients, hemophagocytosis was present in 88%. So pancytopenia is 81%. So mostly all patients had hemophagocytosis. So overall mortality is 9.4%. High ferritin level is associated with late deferments. So our patient satisfies HLS criteria. He had HS score of 236. So 90 to 99% is a probability of HLH. So blood culture, actually, we have sent the bone marrow culture at 20, but after 9 days. So late incubation, it has grown Salmonella typhi. So we diagnosed him having secondary HLH due to Salmonella. So after completing the course of antibiotics, his fever settled. So we discharged the patient. We didn't do any biopsy of mesenteric. So landing points, diagnostic criteria, sepsis versus HLH. So infection as a cause of, we should rule out any secondary causes for HLH first before treatment. Thank you.
Thank you, Shannon. Anybody has a question?
How did you treat this patient?
We gave a course of meropenem and azithromycin for 7 days.
That you had started initially.
Yes, sir.
With this HLH, did you add on anything more?
I think we have read, sir. Have to
discontinue.
Discontinue that. If patient responded, if we discontinued antibiotics.
So just a few comments. When you write down the differentials for acute febrile illness, please go to that. You have to be very careful all this. Why did you write acute viral hepatitis? How do you justify viral hepatitis in this patient? What's a typical presentation of a viral hepatitis?
A low stool.
So they have a phase of prodromal symptoms, fever, myalgias, loss of appetite, and when that starts coming down, the jaundice appears. Right? Any patients who has fever along with jaundice, you would not consider viral hepatitis. So unless you have some of those features, I see you have run them through all the investigations and all of them. Even your enzymes that you see in viral hepatitis are in thousands. Here it is just hundreds. You don't really have that picture of it. You may keep it in the back of your mind, but I guess scrub, lepto, malaria, dengue, entry, those are fine. But any other things, you should have some clinical parameters rather than sending all of them. Did you send all of these things on day one of this person?
No, sir. During the course of the stay.
So you send the initial ones and they were negative.
Negative is the next.
So this have to reserve acute viral hepatitis. The justification should be there. Infective endocarditis if you have some cardiac findings, or autoimmune malignancies only if your first set of investigations are negative, that you should go for it. And it should not be one list, any fever, 8 days, you send the list, is not the message we should give. Just something.
You just show us the counts of your patient.
So then the cytopenias.
Platelets 87,000. Initial WBC is also 3,500.
So is it just because we looked for HLH and we found some criteria as we label these patients, but didn't really change the management? How many days did it take for the fever to settle?
Only 6-7 days he had fever.
6-7
6-7 days.
He started Azithro at
Meropenem. Yes. 1 gram motivation.
So it still took 6 to 7 days.
7 days.
The patient was stable all through.
Yes, sir. Stable.
And why did you think of HLH?
Because all the primary investigations were negative. So we did a bone marrow and this saw some hemophagocytosis.
Because but you said, so the learning point is that sepsis can also have hemophagocytosis. That itself is not a criteria.
Yes.
Maybe the last two that you mentioned, if they are positive, which is absent in sepsis, may NK cells or the CD25. So apart from those two, all the others can be there, and that is something to be kept in mind. Some of the low counts can be in favor of entry. If you're looking at it, scrub and all usually will have high counts. Dengue may have normal or low counts. Enteric may have normal counts. Platelets are little on the lower side. So clinically, those are the AFIs, among the usual AFIs, all of the things may fit in. And really speaking, secondary HLH, you're not going to treat them, otherwise referring is treating. So even if I didn't do all those things, the patient would have responded and done well. And the patient didn't have any clinical deterioration to think of anything else or give them any other treatment.
Okay, thank you, Shannon.
Thank you.
But we are joined online also by some of our friends. Would anybody like to make any comments or ask any questions? Okay, if not, we'll close, and I think it'll be a tie between Bobby and Shannon. The other people are unwell, so two are not sick.